Hello everyone, in this video I'm going to talk about the goniotomy. I was to include this topic under laser procedures, thinking goniotomy was laser also, but laser goniotomy has a different name and it is called as trabeculotomy. Yeah, that is called as trabecular puncture. It is called as laser trabeculotomy. Now, trabeculotomy, you should be able to differentiate between the trabeculotomy, its variants, and goniotomy, then gonioplasty, photoablation, goniosynechialysis, trabeculodialysis, trabeculectomy, canaloplasty, ab internal trabeculectomy, trabectome, and ab externo trabeculotomy. So, first we'll learn about the goniotomy, and at last I'm gonna talk about what's the difference between the goniotomy, gonioplasty, then goniophotoablation, goniosynechialysis, then the difference between the goniotomy and trabeculotomy and trabeculectomy and the variants. And goniotomy can be added under the heading of the variants of the trabeculotomy. So, goniotomy is a procedure of the choice in treatment of childhood glaucomas and not effective in the adults. So, we'll read about the goniotomy from Shield's textbook of the glaucoma. I have 6th edition here. It's an old book relatively. So, we'll start. In 1893, the Italian ophthalmologist Carlo di Vincentis described a new operation that attempted to open Schlemm's canal by incising the angle tissues without visualization of the angle because of high complication rate and poor results in adults with chronic open-angle glaucoma. This operation was initially abandoned. With the advantage of clinical gonioscopy, Otto Barkum modified the technique as an operation for primary congenital glaucoma in 1938, dubbing it goniotomy. Gonio stands for angle and tomatin means to cut. This effective operation for congenital glaucoma dramatically improved the previously dismal prognosis for this condition. The technique for performing goniotomy has remained essentially unaltered for more than 50 years, a testament to the effectiveness and widespread use of this elegant, brief congenital sparing procedure as an initial intervention for primary congenital glaucoma. Although the aim of goniotomy is to open a route for aqueous humor to exit the antechamber into the Schlemm canal by removing obstructing tissue, the precise mechanism by which the pressure reduction occurs remains obscure. Successful goniotomy does appear, however, to reduce the IOP by improving facility of aqueous outflow. Goniotomy enjoys its greatest success in the treatment of primary congenital glaucoma presenting between 3 and 12 months of age. But it may also be used in other primary developmental and secondary glaucomas, although with reduced success. Examples of these other primary glaucomas include juvenile open-angle glaucoma and early onset glaucomas associated with Sturge-Weber syndrome, neurofibromatosis, and Lowe syndrome. Several secondary glaucomas may respond favorably to goniotomy in some cases, including glaucoma complicating chronic anterior uveitis and selected cases of aphakic glaucoma presenting early after congenital cataract surgery. Goniotomy has been advocated as a prophylactic procedure in congenital aniridia before glaucoma develops, but its use in this setting is particularly technically challenging. So it is most effective in children developing the childhood glaucoma between 3 months to 1 year of age, where it has got higher success rate. And also it can be used in aphakic glaucoma cases, in aniridia cases. Now, pre-operative medication should ideally be used for several days before planned goniotomy to maximally reduce the intraocular pressure and clear the cornea. Medications often used include oral acetazolamide or topical donzolamide together with apraclonidine, 0.5%, and judicious use of topical beta blocker In selected cases, to produce meiosis, pilocarpine 1% to 2% should be placed on the eye just before it undergoes surgery to promote meiosis and thereby aid in protecting the crystalline lens from injury during the procedure. So we want the meiosis with pilocarpine 1% to 2% to protect the crystalline lens from injury during the surgical procedure. Acetylcholine chloride 1:100, for example myocol, may be injected into the antechamber if necessary to promote further meiosis. Approximately 0.5% may be applied to the eye just before the surgery and may help decrease intraoperative bleeding. Now basic technique. Basic technique of goniotomy. Goniotomy is performed by using a surgical gonio lens and a goniotomy knife or needle. There are several available types of gonio lens. In addition to the round-domed Barkan gonio lens, including the Lister modification, which includes irrigation, the Swan-Jacob lens, which incorporates a handle, as well as the Hill gonio lens and Carr surgical gonio lens, both of which allow the surgeon holding the lens also to fixate the globe. So there are modifications in the gonio lens to ease the procedure. So there is a Lister modification in which it includes the irrigation system along with the gonio lens, and Swan-Jacob lens, which has got the handle, it incorporates a handle, and Hill gonio lens and Carr surgical gonio lens, both of which allow the surgeon holding the lens also to fixate the globe. Numerous modifications of the Barkan goniotomy knife have been described. So we need a gonio lens and we need a goniotomy knife. So it's a Barkan goniotomy knife have been described, including attached fiber optics for intraocular illumination. Numerous modifications of the Barkan goniotomy knife have been described, including attached fiber optics for intraocular illumination. A non-tapered swan knife or needle knife enters the antechamber easily and cuts in either direction. Alternatively, a disposable 25 gauge needle attached to a syringe containing viscoelastic or myocol may be used in place of a knife. So we can use this goniotomy knife, or we can use 25 gauge needle attached to a syringe containing viscoelastic substance. That is a better choice because we can maintain the antechamber during the procedure and while we store the needle or the knife, here needle. So this allows the antechamber to be deepened before incision and to be maintained on instrument removal. The author prefers the latter method, that is 25 gauge needle with attached syringe, using only enough viscoelastic to ensure chamber maintenance or needle withdrawal. Enthusiastic use of the viscoelastic may acutely increase corneal edema by increasing intraocular pressure, thereby degrading the surgeon's view of the angle structures. To perform goniotomy safely and effectively, corneal clarity must be sufficient to allow an adequate view of the angle. So corneal clarity is important to carry out the goniotomy. So how to ensure this? We have to maintain the intraocular pressure in the normal range before the surgical procedure. So it can be achieved with the glaucoma medications, and just prior to the surgery, prompt application of sodium chloride 5% to the cornea, these are the drops, to the cornea under anesthesia may improve the angle view in borderline cases. Although corneal epithelial scrapings has been described to facilitate an angle view for goniotomy, corneal stromal edema often persists after epithelial removal. In this setting, trabeculotomy may be preferred procedure. Alternatively, endoscopic visualization has been used for goniotomy in the setting of the corneal opacification. So in this paragraph they are saying that corneal clarity is very important to perform this procedure, and if the corneal clarity is not there, then it is not achieved with anti-glaucoma medication, sodium chloride drops and corneal epithelial scrapings, because if it is a stromal corneal edema, it's very difficult. Then we can go for the trabeculotomy. Okay. So post-operative treatment includes the use of topical antibiotics, steroids, and miotic agents. Miotics are often omitted, however, in cases of uveitic glaucoma, these are omitted miotics. The baby's head should be kept elevated. A car seat works well for this, and the eye should be shielded for 1 to 2 nights until any hyphema has settled. If bilateral goniotomies are needed, they may be performed in a single anesthesia session as long as all instruments are sterilized or replaced, all drapes, gowns, and gloves are replaced, and the fellow eye is re-prepared and draped in sterile fashion after the first procedure. So, if we want to open both the eyes at the same time in a single setting of the anesthesia session, there should be separate set of the sterile instrument for the other eye along with the all drapes, gowns, and gloves. Mild to moderate hyphemas commonly occur after goniotomy, but they almost always clear rapidly without sequelae over several days. The complications after goniotomy are rare and include iridodylisis, cyclodialysis, and the appearance of small peripheral antisynechiae in the incised angle, damage to the crystalline lens, and retinal detachment in eyes with high myopia. The results of goniotomy should be elevated weekly in the immediate post-operative period and are often evident by 3 to 6 weeks. So after weekly assessment is done in the immediate post-operative period of goniotomy and the results are evident by 3 to 6 weeks. Gonioscopy after successful goniotomy often reveals a widened angle in the previous incision site with improved visibility of the ciliary band and scleral spur. Scattered peripheral antisynechiae may sometimes develop in the bed of the goniotomy and may even partly obscure a view of the incised angle. Because 4 to 5 clock hours of angle tissue are incised with a single goniotomy repeated procedures, in untreated portions of the angle may enhance pressure control in selected cases. Goniotomy may fail to control infantile glaucoma in some instances because of improper placement and depth of the angle incision or the obliteration of the incision by peripheral synechiae. So failure can be because of the improper placement of the incision, then improper depth of the incision and presence of the peripheral synechiae, obliteration of the incision side by the peripheral synechiae. Not presence, development of the peripheral synechiae at the incision side. In approximately 10% of the cases, if the first two procedures have produced substantial but still inadequate IOP reduction, a third goniotomy procedure may help further lower IOP. So goniotomy can be repeated first, second, and third, not more than third time because all 12 clock hours will be covered. So the success of goniotomy in controlling glaucoma varies with the causes. The success of goniotomy in controlling glaucoma varies with the cause of glaucoma. The best results 80% to more than 90% success after 1 to 2 procedures are achieved in infants with primary congenital glaucoma presenting between 3 months and 1 year of age. Others report lower success of closer to 70% after 1 to 2 procedures. Repeated procedures, lower success rate. In one study of 7 infants treated with 2 simultaneous goniotomies in one eye and a single goniotomy in the fellow eye, no significant differences were noted in the results. So whether you treat one eye or simultaneously both the eyes, there is no difference in the results if you treat one or both the eyes at the same time. Success rates with goniotomy and angle surgery in general are much lower for cases of primary congenital infantile glaucoma presenting at birth or after 12 months of age. Success in these groups is usually about 30 to 50%. So if you are presenting or if the child is presenting with primary congenital infantile glaucoma between at birth or after 12 months of age, then the success rate of the goniotomy to treat it is very low, that is around 30 to 50% only. Procedures related to goniotomy, historical perspective. She reported a modification of goniotomy, goniopuncture, which involves passage of goniotomy knife through the tubercular meshwork and sclera to the subconjunctival space after standard goniotomy. So, goniotomy knife is passed through the puncturing the tubercular meshwork up to the level of the sclera, communicating to the subconjunctival space, the anterior communication. But scarring of the limbal incision limited the usefulness of goniopuncture, so it's not very effective. So goniotomy, tubercular puncture is different and goniopuncture is different. Goniopuncture is to the level of the subconjunctival space and tubercular puncture is to the level of the Schlemm's canal. The Nd:YAG neodymium yttrium aluminum garnet laser has been used to perform tubercular puncture by directing laser energy gonioscopically at the tubercular meshwork. So laser procedure is called as tubercular puncture. It is not called as laser goniotomy. As a tubercular meshwork to penetrate to the Schlemm's canal, success was reported with this procedure in 6 of 8 eyes with juvenile glaucoma over 6-month follow-up period. A technique requiring a large nimble incision, direct goniotomy, has also been described, but it has been superseded by trabeculotomy. So they are talking about the, in short, like ab externo direct goniotomy, but superseded by the trabeculotomy. Trabecular dialysis, a modification of goniotomy in which trabecular meshwork is scraped or retracted from the scleral sulcus. We retract the trabecular meshwork from the scleral sulcus or scrape it with the blunt side of the blade after standard goniotomy incision, and it is done in the treatment of children with glaucoma secondary to anterior uveitis in case of the inflammatory glaucoma, you can say. 60% pressure control reported in a series of 23 such patients. Goniotomy alone is also effective in these patients. Argon laser trabeculoplasty is ineffective in the treatment of childhood glaucomas, and it is not feasible to perform in young patients. So argon laser trabeculoplasty is ineffective in the treatment of the childhood glaucomas, and it's not feasible to perform in young patients. Okay, so you should see okay. So I was to include the laser goniotomy, thinking laser goniotomy is done under the laser procedures, because I forgot in these 2 years whether the laser goniotomy procedure is given or not. So it is not called as laser goniotomy, it is called as laser trabeculotomy or trabeculopuncture, and laser procedure to carry out the goniotomy. So, while studying the goniotomy, it is a surgical procedure. You should know the difference between the gonioplasty, goniosynechialysis, then goniophotoablation. What's the difference between goniotomy, then trabeculotomy and trabeculectomy, and the variants of the trabeculotomy. You can say the goniotomy is a variant of ab interno trabeculotomy, because in that a communication between the anterior chamber and the Schlemm's canal is made. But you can see, I could see the difference that anterior 1/3 is incised in goniotomy, and in trabeculotomy the establishment between the communication between the anterior chamber and the Schlemm's canal, excising the or destroying or cutting off the trabecular meshwork. That's the trabeculotomy. It can be ab interno, ab externo. It can be done using trabecular puncture, that is called as laser goniotomy. It's not laser goniotomy, it's a laser. It is called as laser trabeculotomy or trabecular puncture, where the Nd:YAG laser it is used to establish communication between the anterior chamber and the Schlemm's canal by puncturing the trabecular meshwork with the laser energy. So what is gonioplasty? Gonioplasty is laser peripheral iridoplasty we saw, where the laser or balls are applied to the periphery of the iris, so it contracts and it widens the angle, especially in the plateau iris, that we have already seen the laser procedure in the last video. Then laser pupilloplasty, it has no gonioplasty, but laser pupilloplasty, where the balls are applied near the pupillary margin to dilate the chronically constricted pupil. Now, what is goniosynechialysis? So goniosynechialysis, in which the peripheral anterior synecchi, these are treated, and for that cyclodialysis spatula with an irrigating system attached. The synecchi are treated under direct gonioscopic visualization, that is called as goniosynechialysis. It involves the deepening of the anterior chamber with the sodium hyaluronic acid and separating the synecchi from the trabecular meshwork with an irrigating cyclodialysis spatula under the direct gonioscopic visualization. Now, what is cyclodialysis? We'll see it later on. Now, gonio-photocoagulation. What is gonio-photocoagulation? Obviously, new vessels at the angle crossing the scleral spur or growing over the trabecular meshwork. These are treated with the laser energy, and it is usually done when the retinal panoretinal photocoagulation is not working, and it is contraindicated in the florid open angle stage of the neovascular glaucoma because of the risk of the hemorrhage and high FEMA. and it can accelerate the closure of the anterior chamber in the florid open angle stage of the neovascular glaucoma. So that was about the gonioplasty, goniopuncture, goniosynechia and goniophotocannulation. Goniopuncture is what? When the goniotomy knife is proceeded, trabecular mesh is inside, anterior third of the trabecular mesh is inside, proceeding to the Schlemm's canal, it is incised. When the sclera is incised and the communication between the anterior chamber and the subconjunctival space is established, that is called as goniopuncture. Now, what is trabeculotomy, laser trabeculotomy or trabecular puncture? It is to treat the glaucoma by application of the laser energy to the trabecular meshwork where attempts to create holes to the trabecular meshwork into the Schlemm's canal. That is establishment of the communication between the anterior chamber and the Schlemm's canal. So you should know the canaloplasty also, canaloplasty where the Schlemm's canal is exposed. Okay, it's the viscoelastic agent is used to dilate the Schlemm's canal, and it is the transconjunctival approach. Then 10-0 chlorine suture is tied under tension within the Schlemm's canal. Then the inner scleral flap is removed, outer scleral flap is closed. Because the trabecular meshwork and descemet membrane are left intact, this is not considered a penetrating procedure, that is a canaloplasty. AB internal trabeculectomy or trabectome. AB internal trabeculectomy refers to the removal of the trabecular meshwork tissue from an internal approach. Several different techniques have been described, such as trabeculopuncture, goniophotoablation, laser trabecular ablation, and goniocurettage. All of these procedures, including the use of the trabectome, are variations of the goniotomy, which is incision without removal of the trabecular meshwork, allowing for direct communication between the anterior chamber and the Schlemm's canal. Through a temporal clear corneal approach, a probe is inserted through the trabecular meshwork and into the Schlemm's canal. Thermal ablation, it is used to remove the nasal trabecular meshwork and internal wall of the Schlemm's canal for 60 to 140 degrees. That is AB internal trabeculectomy or trabectome. You can refer the Shale's textbook of the glaucoma. It's the 6th edition given on the page number 470 for more detail. AB internal trabeculectomy. Now, what is trabeculotomy? Incisional trabeculotomy. In this, the communication between the anterior chamber and the Schlemm's canal, it is made through the transconjunctival approach, that is trabeculotomy. And the basic principle of this operation is the creation of opening the trabecular meshwork to establish a direct communication between the anterior chamber and the Schlemm's canal. It is generally performed with incisional surgical techniques, although laser techniques are also being evaluated. Trabeculotomy in children is discussed in detail chapter 4. So that was all about the difference between goniotomy, gonioplasty, goniosynechia, goniophotocannulation, goniopuncture, trabeculotomy, trabeculopuncture, trabectome, AB internal, AB external, trabeculotomy. So you should read about it for better understanding, because I'm very fast in this video because I have to complete it. I have less memory in my mobile. For better understanding, I have added some videos on goniotomy, and to understand the difference between the goniotomy and trabeculotomy, I have added those surgical procedures also at the end of this video. You can see them because this is not an explanatory video. It's like a video audio book. This is for my own understanding, because we don't see the texts are read, videos are given, the practical approach is given on YouTube. There are so many videos on goniotomy. Less videos, not so many, less videos are there on goniotomy on YouTube. Even the articles are less. I read one article, but this is enough. This textbook of glaucoma is enough. I'll see if it is given in Arvin. I'll read that too later on tomorrow. So that was about the goniotomy. So you can see these videos at the end of this video to understand the difference between goniotomy, trabeculotomy, and trabeculectomy. And I'm not gonna explain because it will just waste time. The videos, the procedures are self-explanatory if you watch them, and nobody reads the textbooks, standard textbooks. Like so many people don't read. They go for the notes because they want to pass the exam, and we don't have that much time during the completion of the graduation, post-graduation. So I'm making it available. It is for myself first as a storage, because I don't have a memory in my mobile. I don't have that much storage to store all my audio books. So I'm making these audio video books and making it available to myself here. And also, if it benefits you, it's good. So thank you so much for listening to me patiently. Tomorrow we'll see if goniotomy is given in Arvind. Otherwise, we can proceed with the laser iridotomy. We have actually I thought laser goniotomy is also there, but laser goniotomy is called as trabeculotomy and trabeculopuncture, laser trabeculotomy and trabeculopuncture that we have already discussed. So that's it all for today. Good night. Take care. Bye.
So basically, when we talk about the management of congenital glaucoma, we have three terms. One is a goniotomy, other is a trabeculotomy, and the third one is a trabeculectomy. So what are the differences between them? So let's say first we talk about the goniotomy, which is basically done in those patients who have clear cornea and who have a congenital glaucoma. So what we do is we basically, let's say this is the anterior chamber. Okay, so I go with a blade inside the anterior chamber, and with the gonioscope I see where are the angles, and I basically pierce the trabecular meshwork. Okay, I open the trabecular meshwork, so the pathway basically opens and there is a drainage. This is called goniotomy. Second surgery is a trabeculectomy. In what I do in a trabeculectomy is, this is the anterior chamber and this is the sclera. Okay, above the sclera there is a subconjunctival space. So I basically remove the conjunctiva and then I make a opening between the sclera and the anterior chamber so that the aqueous humor can drain into the subconjunctival space through that opening, which is called ostium. This is called trabeculectomy. Third procedure is a trabeculotomy. So what is there is, I go through the subconjunctival space, I open the conjunctiva and then I basically open the Schlemm's canal. Okay, so I opening the Schlemm's canal, so that what that would do is that would increase the drainage into the Schlemm's canal. So it is above the sclera, I basically open the Schlemm's canal, that is a trabeculotomy, and opening the angles, that is the goniotomy.
This video may have graphic eye surgery content. Today's video is an eye surgery for glaucoma called goniotomy. Gonioscopy opens the trabecular meshwork, allowing increased outflow of the eye and lowering intraocular pressure. Here we go. We're going to start entering the trabecular meshwork with the KDB Glide goniotomy device. We're entering Schlemm's canal and opening the trabecular meshwork. This will increase outflow and help facilitate treatment of the glaucoma. We see nice strips of trabecular meshwork being removed. As we re-enter the canal here, we can extend the length of the treatment. Now going back the other direction, 180 degrees. This is a backhanded approach to add increased clock hours of treatment for the goniotomy. As we increase the treatment, we can also rotate the gonioprism sitting on the cornea, allowing increased view to the lateral aspects. After all is said and done here, I think we get about 5 clock hours of treatment, which is pretty remarkable for a temporal approach to access the nasal aspect of the angle. Thank you all for watching.
This is a video of a goniotomy surgery performed by Drs. Chen and Walton. The patient is a 7-month-old Portuguese boy with infantile glaucoma of the left eye. Here you can see that the assistant has already put the Elschnig-O'Connor locking forceps on the superior and inferior rectus muscles. The surgeon's left hand is holding the Barkan lens, which has already been placed on the cornea. In the surgeon's right hand is a non-tapered swan goniotomy knife, which is being entered into the anterior chamber through the peripheral cornea. At this point in the surgery, the right-handed surgeon's right hand is actually tilted back towards the surgeon. This is such that when the knife is entered into the anterior chamber and approaches the opposite angle, the hand actually straightens out so that it is in a more comfortable position during the actual goniotomy surgery. For a right-handed surgeon, I find it easier to do the surgery from right to left. Here you can see the goniotomy knife as it is engaging the trabecular meshwork. There is also some contact later with the sclera, so that when the incision is initially started, it is not as smooth as one would ideally like. However, this is not uncommon, and it is very easy to readjust the knife so that it engages only the trabecular meshwork. As one gets past the light reflex here, I want you to watch, because in the wake of the knife you can actually see a white line, which is the incision, right here. As the incision is completed, the assistant can rotate the eye clockwise to maximize the length of the incision. The knife can then be withdrawn over the iris. This is to minimize accidental trauma to the native lens. Then the Barkan lens can be placed over the wound to minimize fluid egress from the eye. Here the eye is reinflated with BSS. This minimizes adhesions of the iris to the incision. A smooth tear holds the wound closed until it is then closed with 10-0 vicryl. Here is an interesting view of the angle right after goniotomy. This is not an atypical amount of heme.
This is a surgical video demonstrating an ab-externo-trabeculotomy. A focal superior peritomy has already been performed, and we applied cautery for hemostasis. Here we are creating a partial thickness triangular flap with a super sharp blade. We will lift the apex of the triangle and score along the bed of the flap to achieve the desired thickness. Anteriorly, we are moving deeper to reveal Schlemm's canal. We then score posteriorly in a vertical fashion until we enter Schlemm's canal, which is noted by a slight flow of aqueous. The Harms trabeculotomy probe is then introduced in a left-facing manner. The probe is moved circumferentially along Schlemm's canal, which is visualized with the help of the external probe. The traction suture is then grasped to provide countertraction as the probe is directed towards and into the anterior chamber, thus opening and unroofing Schlemm's canal and trabecular meshwork before being removed. A gush of aqueous is noted. The procedure is then repeated with the Harms probe in a right-facing manner. A 10-0 nylon suture is then placed through the apex of the triangular flap and adjusted for a tight and watertight closure. The conjunctiva is then advanced to the limbus and closed with 10-0 nylon sutures in an interrupted and running fashion.
So we have a 4-year-old with congenital glaucoma, no prior surgeries, and the vision in the right eye is hand motion. So we're doing trabeculotomy. So the conjunctiva was being pulled up too much with that traction suture. I'm going to put the traction suture in the cornea. I sometimes don't like the corneal traction sutures because they can pull out. They can also be problematic if they go too deep and you start to lose your chamber depth. Trabeculotomy has the advantage of being able to be performed in all glaucoma patients, whereas goniotomy you can only do in an eye with a clear cornea. I think of those two procedures that they're both essentially equally effective. So we have a couple options here. You can do the trabeculotomy from the top at the 12 o'clock or temporal. Those are the most common positions. I'm choosing to go temporal so that this is the conjunctiva that will be disturbed. If the child needs another procedure such as trabeculectomy or tube shunt, we'll still have normal conjunctiva superiorly to work with. We need about a 4 millimeter area here. Take the cautery.
What is your preferring shape for the scleral flap?
Well, first of all, I don't think it matters. I do a triangle because it's just easy. But whether it doesn't have to filter, right? I mean, you're not going to have filtering out of this like a trabeculectomy. It doesn't matter, right? All we need is access to Schlemm's canal. If I do a trabeculectomy, yeah, I would still do a triangle. I really don't find them to be terribly helpful in children. To form this triangular flap, there are lots of different blades you can use. Some people use a 75 blade. At home, I have what's a guarded blade. It's a 300 micron guarded blade, and you just press it down, and it won't go more than 300 microns deep. So I'm going to start our triangular flap here. And I'm being rather careful because this eye's really been stretched out, so I'm watching my depth as I do this. I'm aiming for half depth. Of course, you don't want it too thin, but you also don't want this to be too thick. But again, keep in mind, this is a ophthalmic eye. The corneal diameter is 14 millimeters. So what might be normal depth in an adult is going to be less in this patient, or actually it's going to be deeper, because this sclera is just thinner. It's been stretched out. What we want to get to is kind of the blue-white junction. So some of the landmarks that we're looking for here, sometimes you'll see little bleeding vessels. I think there's one right here at the tip of the spear. Those are typically little vessels draining Schlemm's canal. There's one right there. Okay, so those are draining from Schlemm's canal. So I like to see those. Those tell us about where we want to be. In this eye, since it's so stretched out, there's not a real super distinct blue-white junction, and that's probably, but it's about right here. I'm going to do about a 2 millimeter radial incision just anterior to where these little draining vessels are. And we're essentially just going to go down real slow until we start to see some aqueous come through this. A little fluid there. Before I do anything with the trabeculotome, I'm going to try and confirm where we are with this 6-0 proline. So I'm taking the traction off here. Let me zoom out a little bit. And you see how easy that advances. And we're looking to make sure that it's not in the anterior chamber when we strum it here. I'll take another piece of that 6-0. I'm going to cannulate the other direction. So these are not only they confirming, but they'll stay there as markers, because if you lose your anterior chamber depth, it's very hard to then find Schlemm's canal. So it's a bit of a way to cheat and keep that place. And it should advance very easy. If it doesn't advance easy, then you have to wonder why. Now I'm going to change the lighting so we can show the anterior chamber better. So trabeculotomes come in two directions, one to the left and one to the right. I'll show you this one. The other one is a mirror image. You only use the bottom rod. The top one is just to give you reference as to where the bottom one is. because when you rotate this in, you want to be in the plane of the iris. I'm going to rotate it in now, so watch here. Okay, and there's a little bit of blood, which is normal. And I didn't rotate it 90 degrees because I didn't want my chamber to collapse yet. Going to the other direction now. And now I'll go past 90 degrees this time, okay? And I'm going to put my traction back on. I'll take the 9.0 nylon. There's really not much resistance when you do that. These might filter for a while, but with no anti-metabolite, it's just going to seal off. The reason I don't like trabeculectomy so much is that you have to put so much mitomycin on them that the blebs end up very thin and cystic. In order to get the bleb to work, it becomes so thin and cystic that there's a significant risk of endophthalmitis lifetime. So this little bit of blood that's in the anterior chamber, I usually don't bother to irrigate that out. It'll be there for a day or two and then be gone. You see the same thing with goniotomy. Trabeculotomy has the advantage of being able to be performed in all glaucoma patients, whereas goniotomy you can only do in an eye with a clear cornea. Goniotomy is a nice technique. Problem is, I imagine, especially usually in developing countries, the referral system is not very prompt, and so the patients arrive late with cloudy corneas. Yeah, I think you could do either one, Nate. It's pretty much surgeon's choice when you have a cornea that's relatively clear like this.
Okay.
The reason I chose trabeculotomy is that if you're going to learn one technique that you can do on every patient, it's trabeculotomy. So because the underlying problem is a dysgenesis of the angle, you could do this surgery on anyone with congenital glaucoma. And the nice thing is that once you open the angle, if you get a pressure result that's favorable, it'll stay that way forever. Something I think that's interesting about this patient is relative lack of Hobstria and corneal scarring.
Did you measure the intraocular pressure?
Oh, yes, good question. We did at the start. It was 31 on the right eye and 35 on this eye.
A 22-year-old man, a case of uveitic glaucoma with a pressure of 40 with topical medication and also oral Diamox, has a pressure of 40 and the plan is performing GAT procedure. After creating required corneal incision with the aid of a gonial lens, an incision is created over the trabecular meshwork to get access to the Schellem's canal. In this part, an MVR blade is used. Next is inserting the suture inside the anterior chamber and then cannulating the Schellem's canal. To insert the suture inside the Schellem's canal and cannulate that canal all the way around the anterior chamber, a microforceps is used, and the suture is pushed inside the Schellem's canal. As you can see here, the other end of the suture is coming out from the other end of our incision. To assure that the suture is exactly in the Schellem's canal, we need to take a look with the gonio lens, because if there's any PAS, there's a chance that we may induce iridodialysis. As you can see in the mirrors, the suture is in the Schellem's canal and there's no PAS. To perform the trabeculotomy, we need to hold one end of the suture inside the anterior chamber and then pull the other end out of the eye. The last part is removing the OVD. As you can see, after removing the OVD, there is bleeding from all over the angle, and that's one of the complications of this procedure. But fortunately, the bleeding usually is resorbed after a few days or few weeks. And this patient did really well, and the pressure was below 20 with one medication 4 months after the surgery.
This is a surgical video depicting a trabeculectomy with mitomycin C. A 7-ovical traction suture is placed in the superior cornea. A 1-to-1 mixture of lidocaine and mitomycin is injected far superiorly, distal to the ventral peritomy, which you see being performed here. A focal superior peritomy is performed using Westcott scissors. Blunt and sharp dissection is used to remove tenons, which reveals bare sclera. Gentle dissections performed to extend the pocket posteriorly. Here we see the outline of a rectangular, partial thickness scleral flap being created using a 30-degree super sharp blade. A toothed forceps is then used to elevate a corner of the flap, and dissection is performed both to release adhesions and ensure proper depth of the partial thickness flap. The flap is carried anteriorly. Tenno nylon sutures are pre-placed at the corners of the flap. Entry into the anterior chamber is made at the far anterior extent of the flap using a 30-degree blade, and that same blade is used to excise a block of scleral tissue to create the ostium for the flap. Toothed forceps and Vaness scissors are used to perform an iridectomy. The pre-placed sutures are tied using slip knots to allow for adjustment of tension and titration of flow. The knots will then be rotated and buried. BSS is injected into the anterior chamber with adequate flow through the flap and stabilization of the anterior chamber. Here, the conjunctiva is advanced to the limbus and closed using 10-0 nylon wing sutures. Long passes are preferred here to allow for easier rotation and burying of the knots. Nasally, you'll see an area of redundant conjunctiva that's secured in a running fashion with 10-0 nylon suture, which ensures a watertight closure. Here we see that area of redundant conjunctiva being secured with 10-0 nylon in a running fashion. Gentle pressure shows easy elevation in the bleb. A Weck cell is used to confirm a watertight closure.